All right. Tonight's webinar features a very special guest and a dear friend of the Breast Cancer Coalition, Dr. Pebble Kranz. Dr. Kranz is a family physician and expert in menopause and sexual medicine. She completed medical school at Brown University and her family medicine residency at the University of Rochester, where she focused on the psychosocial aspects of primary care. Dr. Kranz went on to complete advanced training in sexual, menopause, and gender medicine, earning fellowships from the European Committee on Sexual Medicine and the International Society for the Study of Women's Sexual Health, and certification from the Menopause Society as a menopause practitioner. She's very impressive, if you can't tell. She is also an advanced practitioner in optimal sexual experiences group couples therapy. Pebble is the founder and medical director of the Rochester Center for Sexual Wellness, which provides comprehensive care for sexual, relational, and gender concerns in Western New York. She has served on the board of the Scientific Network on Female Sexual Health and Cancer and the Advisory Council of the Breast Cancer Coalition of Rochester. And she consults at the Pluta Breast Center's Sexual Wellness Clinic. So she's just a bit busy. Dr. Kranz is committed to educating healthcare professionals at all levels and the community on medical care for sexual concerns. She is a rare and special gem of a physician with such an intersectional perspective and transdisciplinary training to back it up and fully support holistic health and well-being. We are so lucky she is a part of our wider community of care, and we are thrilled to have her with us and to welcome her as our presenter tonight. So enough of my talking. Without further ado, take it away, Pebble. Thanks for being here with us.
Thank you. I am just delighted to be here. Is my screen showing as intended? Okay. All right. Hello. Hello and welcome. Um, Survivors, partners, caregivers, patient advocates, um, humans with a cancer experience. I'm so grateful to the Breast Cancer Coalition and to Rachel for inviting me to do this talk. And I'm nervous because this is a talk that is a little bit different than my usual medical presentation fare. Uh, this next hour is not going to be a medical data fest. It's going to be a little more reflective. In case you didn't get the note from Rachel, at one point I will be inviting folks to do a short writing exercise. So if you have a piece of paper and a writing implement, a tablet, a journal, that's going to be helpful. So let's get started. So, in my work with people navigating sexual concerns after cancer, I'm usually meeting them after that most active phase of treatment is over. And that moment can be surprisingly complicated. During treatment, there's so much focus, urgency, and support, and then suddenly all that structure just falls away, and people can feel untethered, not quite sure where to land or even how to land. At the same time, the people around them and or they themselves may expect life to go back to normal, the way it was before. But often it doesn't. And one of the places that that change may show up is in a person's relationship with their body. The body has been through a lot with the cancer experience. And sometimes, in order to get through treatment, the invasiveness, the pain, the fear, the discomfort, people disconnect from their bodies. This kind of disconnection can be protective and important to get through the experience. It got you through this. And it may show up as numbness. It can show up as sort of going on autopilot or feeling very far away. And it can also affect embodiment, the felt experience of being present in your body. Sometimes sensation itself stops feeling neutral. A twinge, a pain, or simply noticing a part of the body affected by cancer can bring someone right back into what my colleague Christina calls cancer land. Not a place of ease, safety, or certainly pleasure. Certainly, it's not a sexy place. For some people, every sensation also can begin to feel potentially alarming. And for others, there's also a deeper loss of trust. I thought my body was on my side, and now it feels unfamiliar, even like it betrayed me. For some people, this disconnection from the body didn't start with cancer. I see this in many of my patients more broadly around sexual concerns. And sometimes I ask, are you friends with your body? Would you go out to coffee? Or are you more like coworkers, getting through the day and getting the job done? Or do you feel like mildly familiar strangers? So fundamentally, this talk is not about any pressure to bounce back sexually or to get back to the relationship you had with your body before cancer. It's about something gentler and perhaps more realistic. Comfort, connection, and presence with yourself. This is an invitation to get curious about what a new relationship with your body might look like now and what feeling a little bit more at home in it might make possible. So as we go through this, I encourage you to take care of yourself. Take what fits, leave what doesn't, do what you need to do to feel comfortable. I'd like to start with one of my very favorite grounding activities. It's called 5-4-3-2-1, and you may be familiar with this. So for myself and for you, I'm going to invite you to notice and name in your mind 5 things that you see around you right now. And when you have 5 things that you see, I'd like you to transition to 4 things that you feel. It may be whatever you're sitting on, if you're seated, your feet on the ground, your skin against your skin inside your clothing. And then 3 things that you hear. And 2 things that you smell. And then 1 thing that you taste. And with that reintroduction to our senses in the present moment, I'd like to talk a little bit more about what can happen with the body in a cancer experience. First, I want to say if your body feels unfamiliar to you right now, you're not failing, you're adapting. After cancer, the body can carry scars, changes in breast or vulvar tissue, weight shifts, hair loss, lymphedema, numbness, fatigue, pain, the sudden onset or the worsening of menopause symptoms. And these body changes also affect sexuality, as it does for most people who have been through a cancer treatment experience. Vulvar and vaginal dryness or irritation is very common. There can be vaginal canal narrowing, genital or pelvic pain, low desire, trouble with feeling aroused, or changes to orgasm, or feeling shut down or ashamed about how the body looks or responds. And some may be afraid of sexual touch, feeling that the body is too fragile for sex, or sometimes pain or bleeding with sex was how cancer came to light. There are, of course, emotional layers as well. In addition to grief about these changes, vigilance to sensation, or this feeling of betrayal from the body, some feel cut off from pleasure or from any sense of being at home in their own skin. And partners and caregivers struggle too, wanting to help, but worrying about saying the wrong thing or creating pressure. So you've probably heard about this idea about self-compassion. Self-compassion asks, how do I treat myself as a person while I'm going through something hard? And that matters a lot in cancer. There's good evidence that self-compassion can help people cope with the distress and suffering in a cancer experience. Now, body compassion is related, but it's a little different. It asks, how do I relate to my body given what it has been through? Not just to me as a person, but to this body, its appearance, its abilities, its limitations, its sensations, its health, and the story that this body now carries. And that's a little different because some people can be fairly kind to themselves in a general sense while still feeling pretty angry at their body and disconnected from it or afraid of it. You can think, I'm grateful to be alive, and still not want to look at, touch, or be touched, or fully inhabit your body. Body compassion speaks to that gap. And this is not about forcing yourself to love every part of your body. It's not about pretending that loss hasn't happened. It's about decreasing avoidance in dealing with the body, reducing hostility toward the body, and building a more workable relationship with the body you have now. And what we know so far is really encouraging. In cancer survivors, higher body compassion has been associated with lower anxiety, depression, loneliness, and better quality of life and resilience. So the question is not, how do I get back to the old relationship with my body? The question is, how do I begin to relate to this body with more kindness, more honesty, and more care? And one very helpful thing about this concept of body compassion is that it's not just a vague feeling, it has some very concrete and practical components. So body compassion has three core components: diffusion, acceptance, and common humanity. First, diffusion means not over-identifying with the body or ideas about the body. It's the ability to step back from harsh body critical thoughts and notice them without automatically believing them or becoming completely merged with them. So instead of my body is ruined, there can be a little more space to say, I'm having the thought that my body is ruined. Or even what I'm feeling right now is loss. Second, acceptance means embracing the body as it is, not because everything is okay and not because you have to like every change, but because fighting reality all day long is exhausting. Third, common humanity is recognizing shared human struggle. All human beings live in bodies that change, age, hurt, disappoint us, fall short of cultural ideals. So concerns about appearance, health, weight, ability, or aging are not signs that something is uniquely wrong with you. They're part of a deeply human experience. So, as an example, imagine looking at a scar, hair loss, or a weight change and thinking, I don't look like myself anymore. Diffusion would allow you to notice that thought as a thought and the pain underneath it without piling on more judgment. You might remember that many people going through cancer struggle with body changes too, and that this distress is a human response to loss, common humanity. Acceptance could sound like, this is hard. I'm grieving what has changed, but my body still deserves care and appreciation. And from there, we can work on making this body compassion actionable. It might mean wearing clothes that feel more comfortable, asking for support, allowing yourself to not only hear, but fully take in a partner's or other loved one's appreciation of your body, speaking to yourself more gently, or connecting with other survivors who understand these changes firsthand. So we do have some evidence. There are 2 slides on data, well, 3. There is some early but meaningful evidence that this concept of body compassion is clinically relevant in cancer survivorship. In this study, investigators looked at 54 patients with colorectal cancer and examined how body compassion related to psychological distress, loneliness, resilience, and quality of life. They were also validating a body compassion scale in this population. The main finding in this study was that higher body compassion was associated with lower anxiety and depression, lower loneliness, greater resilience, and better quality of life. So this is not simply a feel-good concept. It appears to function as a protective psychological factor in adjustment to cancer. One particularly important finding was that the idea of diffusion showed the strongest association with lower distress and loneliness and with higher resilience. And that makes sense. So when people are able to sort of step back from defining themselves by their diagnosis or visible consequences of treatment, they may have more flexibility in how they cope. So this doesn't mean that body compassion eliminates suffering, but it does suggest that helping people relate to the body with less hostility and more care may be a meaningful target in survivorship support. So what about studies in breast cancer? In one study of 79 breast cancer survivors, higher body compassion was associated with lower body image distress. And again, diffusion was a critical component, acceptance also an important protective factor. And that same study also found that highly self-critical, worry-driven, or feeling fused with negative thinking predicted greater body image distress. So this suggests that there are 2 things to work on and that may matter at once: strengthening body compassion and helping people relate differently to repetitive, distressing thoughts about the body. And then we also have some intervention work. The My Changed Body study looked at a brief web-based structured writing exercise focused on cancer-related body changes. Participants found it acceptable, usable, and in breast cancer survivors, it reduced body image distress and improved body appreciation compared with unstructured writing. And so taken together, these studies suggest that body compassion is not only conceptually meaningful, it's clinically relevant in breast cancer survivorship and something we can actually support with practical interventions. So the next question is, what does this actually look like in practice? So body compassion is fundamentally a shift in the central question. Instead of asking what's wrong with my body, we begin asking, what has my body been through and what does it need now? And that often looks like friendly curiosity, naming without judging, openness to change, and small acts of care. And this isn't about performing body love or pretending to love yourself. It's about building a more satisfying relationship with the body you have now. So this, what I'm going to do now is we're going to do a version of that My Changed Body exercise. I'm going to ask you to get out the writing stuff you have, and we're going to take about 2 minutes to write about a specific situation where you felt distress about changes to your body since cancer. For example, seeing yourself in the mirror, getting dressed, being intimate, or even being at a medical appointment. I'm going to invite you to write freely about what happened, what you noticed about your body, and how you felt emotionally. This is just for you. No one else has to read it. And for participants who have not had a cancer experience, we all have something similar, perhaps a change to your body related to age, illness, injury. And I'm going to try to do some music for this time. If the technology sort of works, feel free to turn it down if silence is your preference, or if you find the music intrusive. Also, if you don't feel like doing this right now, that's okay too. You can simply write down the prompt for later, or just listen to the music, go get a drink or a snack. So let's see if this music will work.
You need upon you. Know your value, know your worth. Take a breath that's long and deep. You're carried by the ground beneath. Feel the sunshine on your skin. A lotus flower blossoming. Your journey is your offering. You are here for a reason. Send your roots down through the dirt, anchoring you through the hurt. With every breath lengthen your spine, reaching steady towards the light. Feel the sunshine on your skin. Turn up the wiser voice within. Your story is your offering. You are here for a reason.
Sorry about that transition. Um, I'll ask you to wrap up this part of the exercise, and we're going to move on to thinking about what this experience felt like for you emotionally. And I'm going to invite you to write a few sentences naming your feelings. Um, and for example, sadness, anger, fear, um, and responding to them as you might do for a close friend. So you might say, it makes sense that I feel when I notice because. And then next, I'm going to ask you to imagine a room filled with others who have also been through cancer and now live with changes to their bodies. In what ways might your reactions be similar to theirs? Write a few lines beginning with, many people who have cancer might also feel when, and include your best guesses. And then when you've completed that, from a wiser, more understanding part of you, What would you say to yourself about this event and your body? Try to take a step back and see the bigger picture of what you've been through, and write a few sentences, beginning with the phrases like, given everything my body has gone through, or considering my treatment and recovery, that puts this experience in context. And I'm going to give you a few more minutes with some more music to have some time to think about this after I give you this next final step. Based on what you wrote, list one small concrete way you could show care or respect for your body in the coming week. For example, choosing comfortable clothing, resting when tired, applying lotion to a scar, gentle movement, or asking for support. And so I'm going to give you a few more minutes of music to complete these next 3 steps.
I won't fire, I came out the other side. I chased desire, made sure I got what's mine. And I continue to believe that one for me. Because I'm mine, I walk the line. Where adventures and heartbreaks don't matter. Our final destination. There's no asking direction to places they've never been. And to be loved, we need to know. We'll finally find our way back through the joy and pain that our lives bring. We can do hard things. But it felt like a brand new start. I'm not the problem. Sometimes things fall apart. I continue to believe the best people are free. Sometimes, but I'm finally fine. Swear adventure and heartbreaks don't matter. A final destination that we stop asking direction. Some places they've never been. And to be loved, we need to. We'll finally find our way back home. And through the joy and pain that our lives bring, we can do hard things.
So I'll invite you back. And if we were in a room together, I would love to hear what the experience was for you. So I hope you'll reflect on that for yourself. The next thing Another time, when you have an opportunity, I'm going to invite you to consider writing a short letter to your body using a kind and gentle tone. You might acknowledge losses, thank your body for what it's carried you through, express hopes for how you'd like to relate to it going forward. So, where does pleasure fit into all of this? It's sex. So let's move to thinking about how sexual well-being and pleasure might fit into this body compassion picture. So we can look at having access to sexual pleasure and satisfaction as an outcome of feeling more compassionate to our bodies and feeling more embodied and present with sensation. But I'm also going to invite you to think about how pleasure could be a tool for working towards greater body compassion. But first, we do need to talk more about what happens with a body, cancer treatments, and sexual changes that can occur. So cancer treatments of all kinds, chemo, radiation, surgeries, hormone suppression, even some immunotherapies, can impact many aspects of sexual function and well-being. The ways that cancer treatment has these impacts is varied. It can alter hormone levels, which can change the skin of the vulva and vagina, can change arousal, orgasm, and desire. And then skin changes. The skin, by the way, is our biggest sex organ. We actually have sex with our whole bodies, not just our genitals. These skin changes can change our overall comfort, what feels good, but also genital skin changes can impact both comfort and arousal. The brain, our second biggest sex organ, its environment can be changed by medications used to manage fatigue, mood, pain, neuropathy. And there can also be changes to nerves that communicate sensation, like breast or nipple sensation. This loss of sensation can change a person's arousal template, and it can make orgasm more difficult to access. And there are surgical losses of other erogenous zones, as well as nipple and breast sensation, cervical stimulation for some people, prostate stimulation for people with prostates, and fatigue, pain, and mood changes. Well, no one feels sexy when they feel exhausted and ill, in pain, or depressed. Desire changes, which are the most common concerns that people have, usually have a number of contributors. Hormonal shifts, pain, fatigue, depression or anxiety, medication effects, relationship stress, disconnection from the body, rather than lack of love or effort. There's a very wise sex therapist who says low desire may be a healthy response to sex not worth having. So the way to proceed there is let's make sex worth having, and then the desire may come along. This, of course, isn't a one-way street. There can also be higher desire, sometimes in the face of mortality. Also, there are certainly relational changes that can impact sexual well-being. A shift to a caregiving, cancer-fighting team and loss of a playful, intimate partnership. Sometimes a partner can't cope with the changes of cancer or the potential of loss, or relational role changes can cause stress for an individual. For instance, one person was the CEO of the household, and then in the course of treatment, they can't take on all they did before. And this shift in the role may be attached to one's sense of self and one's identity, and this can create stress. So these are just some of the things that can happen. So let's talk a little bit more about these things and what can be done to help with these changes. But first, a little anatomy lesson, just to make sure we're all talking about the same thing. So you'll hear a lot about vulva and vagina skin changes. So A lot of people have understood this now that the vagina is only one part of the genitals, that people who are born into a female phenotype have. The vagina is this canal that goes from the uterus to the vulva. And the vulva is everything on the outside. So the outer labia, the inner labia, and this area called the vestibule, the head of the clitoris, and the urethra, where the urine comes out. So the vulva is actually really where it's at when it comes to sexual satisfaction and comfort. And there are changes that can occur to vaginal skin as well, but we really don't want to treat the vulva like flyover territory. So what happens with vulva and vagina skin? Genitourinary syndrome of menopause is what we now call this cluster of symptoms that occur at the genitals and that are impacting sexual function, and also includes urinary symptoms. And these happen when estrogen levels are low. The vulvar and vaginal tissues can become thinner, drier, more sensitive, less resilient. And more than half of people who go through a typical natural menopause will experience symptoms like these. But we also see them in other low estrogen states. So lactation, for example, is a low estrogen state, breastfeeding, and in hormone suppressed states, like in cancer treatment. So we actually have genitourinary syndrome of menopause, genitourinary syndrome of lactation, and genitourinary syndrome of hormone suppression. So in the cancer setting, these symptoms can be especially significant. When menopause happens abruptly because of oophorectomy, ovaries being surgically removed, chemotherapy, or pelvic radiation, symptoms are often more severe than they are with a gradual menopause transition. And even after someone has already gone through menopause, further lowering of estrogen for treatment purposes can worsen symptoms quite a bit. So these tissue changes don't matter only during sex. They can cause day-to-day dryness, irritation, burning, and discomfort, even in the absence of sexual touch or sexual play. But during arousal, reduced lubrication can make vaginal insertion, or from the vagina's perspective, vaginal receiving, painful. And that pain can become a cycle. If someone repeatedly endures pain, the pelvic floor muscles may start guarding in anticipation, which can create even more pain and sometimes contribute to more persistent tight pelvic floor muscles. We call this hypertonic pelvic floor dysfunction. So this is not just about dryness. It's often a broader issue of tissue health, pain, and this protective muscular response. Additionally, decreased lubrication can make arousal less accessible, which can be a contributor to difficulty with orgasm. So there are a variety of ways to help both the vulva and the vagina. Our three key principles are moisture, stretch, and blood flow. So the first thing I'm going to talk with you a little bit about is moisture. And for those of you who have heard this little speech before, please forgive me. So we have a variety of different kinds of skin on the vulva. This is my little vulva puppet. Hello. So on the outer labia, on the mons, on the parts of the skin of the vulva that are designed by nature with hair, these have sweat glands, these have hair follicles that have oils. This skin is like the skin and skin of our hands. It can take soap and scrubbing. But the skin of the clitoral hood, the inner labia, the skin that's just outside the vaginal opening, the clitoral head, this skin is much more like lip and mouth skin. And this skin does not have sweat glands and oils and cannot take soap or scrubbing. So water in a hand only to clean those thin skins of the vulva. Additionally, pads or panty liners are designed to wick away moisture from the skin, and that's just what they do. That can also be a contributor to dry vulva skin. What can we do about this? So moisture barriers on the vulva skin, the things that work the best are actually natural oils, coconut oil, olive oil. There are some products like, some fancy products or you can use Aquaphor, but the natural oils work just fine. You're not dousing yourself like a salad. You're just taking a little bit of oil on your fingers and putting it on those thin skins of the vulva. Sometimes just once a day is fine after bathing. Sometimes after every time you go to the bathroom, you wipe, you put on a little oil, you wash your hands. And then we also have a different kind of skin again inside the vaginal canal. This is much more like throat skin or the skin inside, deeper inside our mouths. It needs moisture to pass across the surface. And this skin needs also a different kind of moisturizer and may need more regular moisturizing when we have these more drastic changes with a low estrogen state. There are some non-hormonal moisturizers out there that work really well. I'm happy to share some information with you at the end about some of the ones that I recommend. I also want to signal that topical hormones are also very good for this skin when it becomes thin and dry. And we're going to talk a little bit more about that, topical estrogen and other topical hormones. The other principle is stretch. Stretch that is gentle and non-painful helps vaginal skin remain elastic. And this is where devices like vaginal inserts, also called dilators, can be helpful. Also, we need blood flow. So arousal, any kind of arousal, brings blood flow to this skin, to the vaginal skin, to the erectile tissue of the clitoris. And this all is helpful for maintaining healthy skin of the vulva and vagina. So that can be solo sex, that can be partner sex, that can be any kind of arousal. Vibrators also work by bringing blood flow to the skin. And so vibration can be a really helpful thing to use just for that component of bringing blood flow to the skin. Exercise helps blood flow everywhere. And so that can be helpful. And no smoking is also a good rule of thumb for any kind of blood flow in the body. These are all helpful principles. So what about lube? So lube is wonderful. It's important. I tell people nothing fancy, use often and plenty. And we have a variety of kinds of lube. Water-based lubes are great, often very well tolerated, but when the skin is already dry, they will be absorbed into the skin of the vulva and vagina very quickly. And then either you will need to reapply a lot, because it's sort of functioning as a moisturizer, or it will become frictiony and sticky and uncomfortable. Oils are also a possibility. The one tricky things with oil is that we don't want to use it with a latex condom because this can break down a latex condom. And then silicone lubes are, they remain slippery for a very long period of time. That silicone doesn't get absorbed into the skin, and so it sort of creates a less frictiony environment for a longer time. This is good with pretty much anything, fine with condoms. The only thing that we need to have caution with is silicone. Dilators, vibrators, toys. If silicone lubricant is not washed off immediately from a silicone device, that silicone and silicone together can break each other down. And then we have hybrid lubes that are a combination of water-based and silicone. And as long as you're washing any dilator or toy, again, right away, these are completely fine to use with other silicone devices. So we have some guidance from oncology experts about treatments for the genitourinary syndrome of hormone suppression. We've talked about step one, the non-hormonal methods, but if step one isn't meeting your goals, what's next? So this recommendation includes a recommendation for lidocaine for vaginal receiving, and that's a possibility, though I'm not a big fan. If our goal is simply to get something into the vagina, okay. If the goal is pleasure, something that numbs the vulva and vagina, not so good. So if after 8 to 12 weeks of non-hormonal methods haven't been helpful, we give it the good college try, then it's worth a conversation to consider other options, including hormonal ones like topical estrogen or DHEA. Ospemifene is a medication actually formulated the same mechanism as tamoxifen, and there have been studies in some breast cancer, but there's no consensus here in the U.S. In Europe, it is very commonly used for post-breast cancer GSM. It has more favorable effects on vulvar and vaginal skin than tamoxifen does. And there are other similar medications. Lasofoxifene is another one that has been studied in breast cancer. Fewer vulvar and vaginal skin effects, but really more study is needed. So, vaginal estrogen. So things have changed a lot, and in our community, this has also changed a lot. When I first started giving talks for the coalition, I would mention estrogen, and everybody would sit back in their chairs and say, "No way, you got to be kidding me." But this is now a more common thing that people are discussing with their oncologists. So I'm going to tell you a little bit about vaginal estrogen. There are many formulations available. There are suppositories, creams, rings, and tablets. And this estrogen actually makes labial skin regrow. It increases the elasticity and the stretchiness of the vaginal canal, and it lowers the pH to a place that's more similar to the way that it was in a systemically estrogen replete environment. This helps a huge amount with vulvar and vaginal dryness. It increases the ability to sense vibration. And it is very, very useful after pelvic radiation to help the skin recover. The difficulty here is we have no absolute threshold safety level for estrogen in the blood for breast cancer patients. And as those of you with breast cancer know, often we are using hormone suppressing medications that are working against estrogen in the breast in order to have treatment. And this is true for some endometrial cancer and rarely some ovarian cancer. But the thing that I want you to come away with here is that when somebody is using a estrogen on the skin, the doses actually keep the levels of estrogen in the body as a whole well within the postmenopause range, which is less than 30 picograms per milliliter. Vaginal estrogen causes increases in systemic estrogen levels of between 4 and 8 picograms. So when estrogen is suppressed post-menopause, this minimal increase is really small. I also want to point out that the annual dose of topical estrogen, most of them, is between 0.5 and 7 milligrams a year. And that is actually equivalent to about 1 to several typical birth control pills a year, right? So the estrogen that's in a birth control pill is a synthetic estrogen that is much stronger than the estradiol that is in the vaginal estrogens. And so this is really, again, a very small level of estrogen for the body to manage. And the story between estrogen and hormone-responsive cancers is more complicated than there's estrogen present and that causes cancer growth. It's more complicated than that. We have a number of recent publications about vaginal estrogen and breast cancer. We had a 2025 systematic review and meta-analysis that combined 8 studies, more than 24,000 survivors, found no increase in breast cancer recurrence, breast cancer death, or overall death with vaginal estrogen use. And then we had another 2025 meta-analysis, including nearly 119,000 survivors, also found no significant increase in recurrence, lower overall mortality among people who used vaginal estrogen. That was lower overall mortality in people who used vaginal estrogen. Some of this data is observational, so that is certainly a caution. And the main area of caution seems to be around people who are taking aromatase inhibitors. There's a 2025 review that found a possible higher recurrence risk in that subgroup. Meanwhile, breast cancer mortality death was not increased. In contrast, topical estrogen used with tamoxifen has not been linked in any study to higher recurrence or mortality in recent reviews. There are some early studies that suggest that vaginal DHEA, also called prasterone, doesn't raise systemic estrogen levels in women on aromatase inhibitors and may be safe and effective for severe symptoms. But the data are still from small pilot studies, and there are other studies underway to support this. Meanwhile, I do want to point out that many of the studies that these systematic reviews and meta-analyses are based on are using much higher dose vaginal estrogen than the formulations we currently have available. So, who's a good candidate for vaginal estrogen therapy, assuming that the non-hormonal methods have not been effective? Certainly an early stage disease or a low stage disease, or if there's metastases and limited life expectancy. This is a time to live one's whole life. When hormone receptor status is negative, that is obviously reassuring. Tamoxifen as the endocrine therapy, if the risk of recurrence is considered low, if it's been a long time since diagnosis, and certainly if symptoms are severe and non-hormonal methods haven't been effective. So, a little bit more about pain. Sexual pain often leads to this vicious cycle where there is an anticipation of pain, which increases anxiety, and the pelvic floor muscles guard in reaction to that. This decreases lubrication and arousal and increases muscle tension, and this can lead to more painful sex. And the pain then intensifies this muscle guarding reflex response. And then avoidance, not engaging in sexual play, can enhance that anticipation of pain. So the key here is that painful sex has to stop. Meanwhile, we do see that people who continue to engage in non-painful, pleasurable sexual play improve their pain more quickly. So this may require individuals or couples to kind of rethink their sexual script, as well as the goals of engaging in sexual play. So how do we flip the script? Well, first, communication is really a prerequisite. It's often easier to do sex than talk about it. So if you're stuck in a script or in goal-oriented sex, it may be necessary to talk with your partner about how you can collaborate on flipping the script. So what's this idea of a script? Well, oftentimes we have this idea that this happens, and then this happens, and then this happens, and then this happens, and then we know it's done. And that script can build up in the context of a relationship, or it can be something that's sort of a culturally sanctioned idea. So one way to flip the script is to look at different kinds of sexual play, sort of more as a roulette wheel. Any one of these kinds of partner sex can be satisfying in their own right. And another way to flip the script is to look at a book about sex together. For instance, the Guide to Getting It On. Each partner perhaps has a different color sticky note. You mark the things that look interesting to you, and then together as a couple, you look at the things that have both color sticky notes. Another idea is yes, maybe, nope lists. So really thinking about these are the things sexually that make me go, yes, I want that. These are the things that I would be like, nope, not gonna do that, not interested in that. And these are the things that are like, well, I don't know. I could try and see if I like it and then make a decision. So desire concerns are among the most common concerns that people talk about. 87% of breast cancer patients, up to over half of gynecologic cancer survivors. And this can occur anywhere across the timeline of cancer experience, from the beginning at diagnosis to after treatment is complete. It can be associated with surgical treatments, hormone suppression, treatment-induced menopause, as well as all those other things we discussed. So what can we do about this? First of all, we want to take care of that vulva and vagina skin and make sure there is no pain with sexual play. Then education, psychoeducation about desire and desire differences, ways to work on collaborating around making an environment that feels like a sexier environment within a partnership or for oneself. Individual sex therapy can be helpful. Relational sex therapy can be helpful for those who are partnered. And sometimes switching from an aromatase inhibitor to SERM, like tamoxifen, can also be helpful. We have other methods, the lasofoxifene that I mentioned earlier, and then a number of other medications that have been investigated with regard to helping cancer survivors with desire concerns. Bupropion, flibanserin, vaginal testosterone, and the estradiol vaginal ring. So what about this idea of pleasure. Can we think about pleasure as a tool for body compassion? And I like to think about pleasure in terms of this quote by Mary Oliver, an amazing poet. You do not have to be good. You do not have to walk on your knees for 100 miles through the desert repenting. You only have to let the soft animal of your body love what it loves. So can we think about pleasure more broadly? First, I want to say that pleasure is, of course, not only sexual. It includes relief from pain, comfort, rest, warmth, movement, touch, music, emotional safety, beauty. And then the experience of pleasure can be a way that we reconnect to a sense of being in a body. There's a theory called focusing developed by Eugene Gendlin that invites us to consider the body's intuitive pre-verbal knowledge, and that there is a wisdom that exists within our bodies, and if we pay attention and we can allow that wisdom to emerge. But he also recognizes that the body's voice requires focus and time and quiet to hear. Because really, the voice of our discomfort, the voice of our thoughts is super loud. And the voice of pleasure is often quiet and slow. So, as an idea, I invite you to consider an animal in your life when they're in a comfortable place and how they listen to their body and respond to what feels good, whether that's pushing into your hand as you pet them, or rolling around on the floor, or grooming in a way that feels good. The animals in our lives can be incredible teachers with regard to how to listen to the body's voice. Here are some other tools for pleasure exploration. I'm come back again and again to this phrase, what feels good in this body now? And I invite you to start with a low stakes sensory experience to begin to explore this, whether that is the feeling of a fabric that feels good to you, warmth, water, lotions, a gentle hand on the heart or the belly, stretching, walking, or the variety of other things that might feel good. One of the things that I have noted with a cancer experience is that sometimes what used to feel good, even if it's very simple, like a taste, the taste of coffee, the taste of cinnamon, those things that used to feel good may not feel so good anymore. That doesn't mean that nothing feels good, that nothing tastes good. It may mean that you need to start with a new exploration, just like you did when you first came into the world with this body, to figure out what feels good now. Then I also want you to open yourself up to the idea that you also need to start again with what feels good in this body with another body. And that's another exploration that needs its own time and focus. So I'm going to encourage you to try pressure-free, goal-free, solo or partner touch. Often a time limit is helpful to make sure that there's a boundary so that you can feel safe. And making sure that the limits of this touch, particularly if it's partner touch, are described specifically, and the limits made before you start the touch. I'm going to encourage you to explore also mental pleasures. And one of the ways in which we can do this is to consider expressions of a desire as a wish, a want, not a demand. And so if you let yourself fully take in an expression of desire on the part of a partner as their wish and not something that is needed from you, that can be a helpful entry into mental pleasure. Also, there are so many ways to explore mental arousal. There's romantasy, there are smutty novels, there is a wide variety of ethically made, female-oriented female pleasure-oriented, sexually explicit material out there and available. And that may not be your cup of tea, or it may be a way to explore what feels good to me, what is appealing to me in this body now. And I'm also going to encourage you to practice sexual self-compassion. And what are the fundamentals of that? So sexual self-compassion starts with that question, and it also starts with boundaries, acknowledging that your sexual needs and limits are legitimate. Your body is yours. And in order to feel a sense of yes, we all need a solid right to know. And it is our own job and responsibility to notice our needs and limits, to honor them, and to defend them. I want to encourage you to think, I don't really have to do any particular kind of sex or any sex at all if I don't want to. Meanwhile, can I stay gently curious about what may feel good? Again, to personal responsibility, my arousal, my turn-ons, and my turn-offs are my responsibility to understand, explore, and communicate to a partner without blaming oneself or a partner, but also without abandoning yourself to others' demands. Again, with compassion, when my sexual self is struggling, I'll respond with curiosity and kindness, not criticism or blame. And I give myself permission to change over time. I can keep listening, adjusting, and adapting to whatever this body brings to me. Finally, I want you to think about sexual pleasure as your birthright, not a performance. You don't have to meet any standard to be deserving of pleasure or comfort. So many people have lots of inner voices around sex and pleasure. There may be a fearful part, a grieving part, a protective part. And you don't have to silence those parts. They're there. You can acknowledge them and still move towards a sense of compassion and relationship with the body and pleasure. For partners, caregivers, I would ask you to think about asking, not assuming, and offer your compassionate presence before you offer solutions. Pressure doesn't feel very sexy for anybody. It doesn't give one a place of safety often to make a new relationship or have a sort of openness to new ideas, but curiosity can. And when it's appropriate and when you've discussed with a partner, continue to express desire and body appreciation when your partner can take it in. So for those with these changes, communicating your needs, here are some phrases to think about. Here's what feels hard right now. Here is what helps, and here's what I'm open to. This is some basic sex ed that I wish all adults would get. First, we need to have honest conversations about sexual function, desire, and pleasure. And the earlier we start to talk about sex, the easier it is. We need to be aware that losses and grief about changes are real, but we also can create space to move forward to a new relationship. Consent, even in a long-term committed relationship, needs to be renegotiated as people, bodies, relationships change. And this is really a core component of healthy sex. I want to say there's nothing wrong with lube, often and plenty, and toys. Toys are great. Sex is often how adults get to play together. And bringing toys to the playground is often a good idea. So toys don't say anything about your partner not satisfying you or you being defective in some way. Sexual pain needs to be treated. And there are many differences that people have in relationship. Why should sex be any different? Satisfying sex is so much more than intercourse, than penis-vagina sex, and good enough sex is a really fantastic goal. So this idea of good enough sex, it means really letting go of the pressure for sex to be perfect and focusing instead on closeness, comfort, and mutual pleasure. This is a model by Barry McCarthy that emphasizes intimacy, pleasure, realistic expectations, and flexibility rather than performance. It also reminds us that sex can mean more than intercourse. Touch, affection, playfulness, feeling connected are all parts of a meaningful and satisfying sexual life. And bodies, energy, and relationships change over time, so flexibility matters. The goal is not perfection, it's finding what feels good, connected, and doable for you right now. If you're interested in reading more about this concept of good enough sex, check out Rekindling Desire by Barry and Emily McCarthy, or Couple Sexuality After 60, also by the McCarthys. So healing after cancer is not only about survival, it is about living the life you have in the body you have. Sexual wellness is a part of whole person well-being. It's not separate from health, and it's not too small to matter. Body compassion can start with very small moments, with one gentler thought, one less judgmental moment, one small act of care towards yourself. And when painful thoughts about the body show up, we don't have to fight them, but we also don't have to believe them. Sometimes the most powerful thing we can do is to notice them, make a little space, and not let them tell the whole story. And if there's one thing I hope you remember, it is this: your body may be changed, but it is still worthy of love and care. Your sexuality still matters, and comfort, pleasure, and connection are still possible. I have some resources for you, some wonderful books, and I am available for questions. I really hope this was interesting and useful.
So wonderful. And I hope that everybody who joined us this evening found some useful phrases to use for themselves, to be gentler and kinder to yourself and not be so harsh. I think a lot of us are far harsher on ourselves than we would ever be to our friends. And if any of your friends talked to themselves the way you talk to yourself, you would probably tell them to stop it.
Or you wouldn't be friends, right?
I don't let my friends talk to themselves like that. Well, you cracked me up at a couple points. What was it? Oh, no need to douse ourselves like salads with too much oil. That one, I just laughed. It's like, I'm going to remember that. Um,
Good.
and we do have a few questions, and we have about 8 minutes. I'll try to
Sure.
keep an eye if anything else comes in while we're going through it. Let's see how many we can get through so that we can let everybody, including you, Pebble, get outside and touch some grass, because that is also very pleasurable and embodying. All right,
Mhm.
let's see. Fatigue. Fatigue, as one person expressed, is a killer for desire, and it just
Mm.
gets worse as disease and treatment progress. Ideas? Question mark?
Yes, I do have ideas.
Ooh.
One is um, we have this cultural idea that the end of the day is somehow a great time to have sex. It's a terrible time to have sex. So, really thinking about when your body is most receptive, and when you've had time to perhaps take a little nap, um, that is a perfectly reasonable, self-compassionate, body compassionate way to deal with fatigue and sex. And then also really thinking about not overdoing it, really. Letting yourself have a window of time and activity that and play that feels reasonable for you. Not having a marathon session. So little moments of touch can go a long way.
Yeah, because you can't just jump into a marathon without training.
That's right.
Oh. Yeah, that's no good. Also, we hold ourselves to sometimes unreasonable standards.
Hmm.
Oh, yeah, gentleness. I tell everybody all day to be gentle, and then I struggle with it too. So this is helpful for me. I'm hoping that if I keep saying these things, I'll practice what I preach. All right, let's get to a couple others. Regarding pelvic floor therapy, because
Mm.
all of these things are sort of interconnected. Um, are there places in Rochester, any recommendations in the greater area where insurance is possible to be used? Because it's so expensive and then it's prohibitive for many people to access that, and to feel the best in their bodies that they possibly can.
So pelvic floor PT is an amazing tool. And we are blessed in this community with an incredible community of skilled pelvic floor physical therapists. Many of them take insurance. And so there are some that don't, and some of them that don't take insurance also sort of have a practice model where they'll give you more time and more home exercise program, and then you may meet with them less frequently, which may or may not be good. But the people who we have in town who take insurance, Evolve PT. Um, uh, Limitless has some good pelvic floor PTs. Linden Oaks has some wonderful pelvic floor PTs. There are actually a number in the community. And if I haven't already, I'm happy to share with the Breast Cancer Coalition my running list of the people who I have.
And then I can share it out
Yeah.
after we finish this.
Yeah.
Okay, let's see. We have a couple more.
Okay.
Um, okay, this was an interesting one. Can you please speak about vaginal rejuvenation and how it relates to a cancer diagnosis? Especially, one of our audience members is curious as to whether these types of procedures are safe for women, in this case, gynecologic cancer, people experiencing gynecologic cancers, or realistically practical for those with late stage cancers, so advanced cancers. One that she mentioned she's especially curious about is called Mona Lisa Touch and supposedly restores vaginal health using a minimally invasive in-office laser procedure to alleviate dryness.
Right. So Mona Lisa and other laser procedures are a potential non-hormonal avenue to work on dryness. Here's the thing. They're expensive. They're not covered by insurance. And
Mm,
we don't have any evidence that they work any better than non-hormonal moisturizers properly used.
gotcha.
So, sure, they don't seem to hurt. I mean, sometimes they actually hurt, but
Yeah.
they don't seem to cause problems. But you may be just as well off um, using non-hormonal moisturizers properly. Uh, that is often more frequently, or exploring whether a topical hormone is appropriate. And then finally, I do want to say that we don't have any clear evidence with regard to its safety with skin that has had radiation treatment. So I would be super cautious about that. If you've had pelvic radiation, either brachytherapy or internal radiation or external pelvic radiation. I would be cautious until I had a lot more evidence that it was safe and effective.
Precautionary principle sounds good. When in doubt, wait it out.
Yeah, right.
Okay. Um, oh, a comment in the chat. So encouraging to hear that up to 87% of breast cancer patients, and I'm assuming also gynecologic cancer patients, it's way up there too, experience low desire. Thought I was in the minority. No,
Mm-mm, no.
no, you are in the majority, which for better or worse, that's why we're all